continuing the next topic, that is squamous cell carcinoma. Squamous cell carcinoma of the oral cavity is strongly associated with tobacco use, and there is a synergistic effect if there is a use of alcohol along with that. Tobacco and alcohol synergistic effects. Okay. Carcinoma of the lip, common risk factors include sunlight, fair complexion, smoking, and mechanical irritations. And oropharyngeal carcinoma has been related mainly to tobacco and alcohol, but also to syphilis, oral sepsis, iron deficiency, oral candidiasis, and Fanconi anemia. Most cases occur in men over the age of 50 years, although relative incidence among women and younger patients seems to be increasing nowadays. Okay. Now the microscopic feature of the squamous cell carcinoma range widely in their degree of differentiation. Histologic evidence of squamous differentiation is typically manifest as intracellular bridges and squamous pearls. Okay, we see more squamous pearls in well differentiated and intracellular bridges also seen. Squamous pearls are less in the moderately differentiated squamous cell carcinoma. Histochemical and immunohistochemical features, all cases expressed CK8 and 19, and most expressed CK5, 6 and 13. Molecular genetic features, most common oncogene squamous cell carcinoma involve P16, P53, cyclin D1, T63, phosphatase and tensine homologue. Spread and metastasis, carcinoma of the lip invades adjacent skin, orbicularis muscle. Metastasis occurs primarily by the lymphatic route, the distribution of lymph node involvement depending on the location of the primary tumor. Mainly spread is through lymphatic route and dispersion depends on the primary tumor. More anterior the tumor, the lower the position of the cervical node metastasis. Location is more anterior than metastasis is more lower in the position. Carcinoma of the base of the tongue and oropharynx tend to metastasize to the upper cervical, that is jugulo-digastric level 2 lymph nodes. Okay, metastasis to posterior triangle are rare. They occur in 6% of oropharyngeal tumors and 1% of oral tumors. Cervical node metastasis from these squamous cell carcinoma undergoes cystic degeneration. This means metastasis undergoes cystic degeneration. Hence, this diagnosis is mistaken for branchial cyst with malignant transformation, that is branchial carcinoma. Occult primary lesion is often located in the lingual or palatine tonsil, and it may take 10 years or more to be detected. Treatment is mainly surgery and radiation therapy, singly or in combination depending on the lesion, whether it can be resected or not. Patient with unresectable tumor can be treated with radiation or chemotherapy with palliative intent. Now the prognostic factors of the carcinoma of the oral cavity: location. 5-year survival rate is about 90% for the carcinoma of the lower lip, and 60% for anterior tongue, 40% for posterior tongue, floor of mouth, tonsil and hard palate, 20 to 30% for the soft palate. Stage. Prognosis depends on the staging also. Stage 1 is having a 5-year recurrence free survival rate is 91% as compared to the stage 2 77.2%, stage 3 61.2%, stage 4A 32.4%, stage 4B 25.3%, and stage 4C 3.6%. Grading also is the independent prognostic value. Grading of the deep invasive margin of the tumor provides better prognostic information than the entire tumor. That means deep invasive margin we have to examine for grading of the tumor as compared to the whole entire tumor. Depth of the invasion is also dependent. More is the invasion, poor the prognosis. Tumor size. This does not correlate closely with the outcome, clinical outcome, except for the very small tumors. Yes, tissue eosinophilia. Infiltration of the carcinoma by eosinophils is said to be a favorable prognostic factor. Lymph node involvement. Extracapsular spread, either if outside beyond the lymph node capsule, is an indicator further decrease in survival rate. High risk HPV. HPV 16 and 18 positivity in squamous cell carcinoma of the oral cavity and head and neck sites has been recognized to be a powerful indicator of the improved survival. P16. Overexpression of P16 is found to be favorable prognosis in the oropharyngeal carcinoma.